First of all, I want to thank you very much for Iakovou and his team for inviting me this important Congress. And also I want to underline that I always feel myself in my second country when I come to Greece because of their nice and kind hospitality. I want to speak today about paravalvular leak closure. How do I do it, and tips and tricks for mastering. These all was discussed, but it's a serious complication from surgical and percutaneous valve replacement procedures, and more frequently after surgical mitral valve replacement compared to after aortic valve replacement. And the symptoms are dyspnea, left ventricular enlargement, but heart failure, symptomatic hemolytic anemia. And the heart failure and the hemolytic anemia are the main indications for the closure of paravalvular leaks. When we look at the current techniques, there are two main techniques, surgical and fully percutaneous. The surgical one is the open heart surgery. The other one is the surgical transapical closure, and some of our Chinese friends, transatrial closure. But the fully percutaneous approach is very, very important for the interventional cardiologist, and the antegrade transeptal, retrograde transfemoral, and the percutaneous transapical. But for me, percutaneous transapical is not a good option, and also it requires a surgical skills and also hybrid room, and has a lot of complications when we look at the surgical transapical approach. So to learn antegrade transeptal and retrograde transfemoral techniques are very important. So before paravalvular leak closure, an interventional cardiologist must first understand the mechanism of paravalvular leak development, use the appropriate imaging method for the localization, shape, and diameter of the leak, select the appropriate device, determine the appropriate crossing and closure method before the procedure, use appropriate crossing and closure equipments, and be aware of complications. So we learned these lessons from a lot of our cases, since we are a referral center for paravalvular leak closure in our country. So we published this with European paravalvular leak group, our family, and Manal is also in that family, in Journal of Clinical Medicine, and also the circulation predictors of clinical success after paravalvular leak closure. So mechanism is very important. Why paravalvular leaks are developed at these 2 points. One is the anterior region and the other one is the posterior medial region. Because after mitral valve replacement, the physiologic movement of the annulus change and antiphysiologic movement occurs, posterior contraction and anterior tilting occurs, and these abnormal movement causes abnormal force on the 2 hinge points. This is very important, especially for example, when we close the leaks in our cases with appropriate methods and devices, 1 or 2 years later, maybe, another residual leak or another leak across to these areas can be seen, and this can be one of the accused mechanisms of recurrent paravalvular leak after transcatheter paravalvular leak closure. And the other one is mitral ulnar calcification. Is highly seen, especially in elderly persons in the posterior medial region, and is far from surgical eye. This region is near the circumflex artery, thus surgeons use superficial sutures in this area, and the fibrosa, the central core, and the lowest in the posterior medial region. So it's very important that these 2 points are very, very important for the mitral paravalvular leaks. So defect localization is very important. So this is the clock method according to the transesophageal echocardiography, and the anatomical localization also, the surgical point that where the aortic valve is present at the 12 o'clock, and the left atrial appendage 9 o'clock, and the septum is 3 o'clock, and just opposite of the 12 o'clock, the 6 o'clock, the posterior region. So, but when we look at the fluoroscopy on the left anterior oblique position, this is just a mirror image of the transesophageal echo. So it is very, very important to know also left anterior oblique caudal view for evaluating the, especially where we cross, for example, where we cross inside the leak or inside the valve, or also very, very important to evaluate the impingement after device implantation. So 2D transesophageal echocardiography is still important because you can see the color Doppler, and when, for example, these 2 points are A, B, C, D, E. For example, D is the left atrial appendage. You can easily see the two-chamber view on the 2D echocardiography where the leak localization at the left atrial appendage region. This is a combination of the 2D echocardiography, but the 3D is the gold standard because you can see the where aortic valve is, where anterior region is, where anterolateral is, where anteromedial, and where posteromedial. Here is the medial region, septum. Here is the left atrial appendage, and there is a posteromedial leak, as you see here. And the opposite, I mean the direct fluoroscopic appearance where the anterior and posterior leaks are localized is the right anterior oblique 40-degree cranial view is very, very important, and the anterior leaks usually localize the superior part, the posterior leaks also in the inferior part. So defect shape can be round, oval, crescentic, slit-like, crescentic, cutting edge. These are very, very important for the device, selection of the device. And the defect size is very important, and we had to combine with 2D echocardiography and 3D echocardiography. On 2D transesophageal echocardiography, transverse speed of the paravalvular leak is very important. And on the 3D transesophageal echocardiography, transverse width and the actual length of the paravalvular leak is very important. And for example, for the distal and proximal discs of the device and the size of the device, we usually measure the length of the paravalvular leak. So, sorry. So how do I did? What are the tips and tricks for mastering? For the anterior leaks, I always prefer the transeptal antegrade approach. For the posterior leaks, I always prefer to begin transfemoral retrograde approach, second transeptal antegrade approach with modified pigtail technique. But hardest cases are the medial and posterolateral leaks. In the literature, many people, recommend a transapical approach, but I always prefer to use first transfemoral retrograde approach. These are the equipments: transeptal needle for the antegrade approach, mother and child technique. For the 7 French guiding catheter, long 120 centimeter impress peripheral catheter or navicross catheter, and the thermoguide wire is very important. So technique to cross the leak is a telescopic coaxial system, mother and child technique, 5 French peripheral catheter in 7 French right guiding catheter and 7 French in Aguilis sheath, and modified pigtail catheter technique for posteromedial leaks. This is the transeptal antegrade crossing of an antegrade. Anterior leak after transeptal puncture, we put an Aguilis sheath in the left atrium, and by the mother and child technique, here is the right anterior oblique 40-degree cranial view, and the anterior leak is here, and we cross the defect with the thermoguide wire, and then put a stiff guide wire in the left ventricle, and over the thermoguide wire, we use the specific delivery systems. So retrograde approach is very, very useful for posteromedial and medial leaks, but it's very important to learning curve is very important. Equipments are Amplas left 1, left internal mammalian and modified pigtail catheter, thermoguide wire, and long catheter and long navicross catheter, mostly navicross, Amplas excessive guide wire, and long delivery system like Cook delivery system flex or Cook braided sheet, and now new occlutic delivery system is also very useful for the retrograde approach. Pull and push of maneuvers of catheters to sweep posterior medial region for posterior leaks, and loop and curve technique for medial leaks, and left internal mammalian catheter for anterior leaks. Here is a retrograde crossing of a posterior medial leak. As you see, we made a high femoral puncture because the distance between groin and the leak is usually long, and we had to use a long catheters. And after sweeping to the posterior medial region with the plus left one catheter, we easily cross to the FEC with the Terumo guide wire. The hardest case are for mitral paravalvular leak closure is the medial leaks. Here, as you see how we cross to medial leaks, this is the loop and curve maneuver. When we come to the apex, we make a loop here, usually with the plus left one catheter, and also the regurgitation jet between left ventricle and the left atrium usually allow to sweep the Terumo guide wire into the medial leak. And after crossing the leak, as you see in this case, I didn't make an arteriovenous wire loop, but nowadays I always prefer to use arteriovenous wire loop because of the, especially for the large leaks, because of the passing equipments of the delivery system. With the wire loop, the delivery system can easily cross the defect. So what are the limitations of transapical approach for mitral paravalvular leaks? Needs surgical approach, surgical skills, needs hybrid room, not suitable in cases of apical scar tissue. And we know that these patients are high-risk patients, very frail patients. And transient and permanent impairment of left ventricular function is really problem. Even if transient, it is undesirable in patients with paravalvular leak who have cardiomyopathy as baseline. And the transapical related complications like pleural effusion, bleeding, atrial fibrillation, prolonged intubation, septum hematoma, ventricular septal defect, delayed rupture of apex, false aneurysm of apex, and coronary laceration risk. So it is very, very important for an interventional cardiologist to learn retrograde approach, I think. So, but limitations need to use long 120 centimeter delivery catheters and need to make high femoral puncture, and sometimes this can increase risk of retroperitoneal bleeding, and not a useful approach in patients with peripheral artery disease, and not a useful approach in patients with a concomitant mechanical aortic valve replacement. So in cases of double valves, first, I always prefer to begin with antegrade approach. It is easy for the anterior leaks, but if the leak is posterior or posterior medial, I always begin the procedure with antegrade approach by using a modified pigtail technique to cross the leak. If antegrade approach doesn't work, I always try retrograde crossing of the mechanical aortic valve with wire, but I always check the blood pressure, and I always think about creation of an arteriovenous wire loop. AV loop also useful if the device embolizes. Without AV loop, I hesitate to use large delivery catheters, and I always afraid of complications. These are the cases that we close the leaks with the anterior and posterior leaks without creating arteriovenous wire loop in patients with mechanical aortic prosthesis. Here, as an anterior leak, as you see, we come from the transeptal. It was easy for the anterior leak, but for the posterior medial leak, this is a modified pigtail technique that we used. We pushed the distal part of the agilis at the bottom of the left atrium, and then sent a cut pigtail inside in it, and try to find the exact localization of the posterior medial leak. Sometimes it works, sometimes it doesn't work, but it's a usual maneuver. And then in the first case, we used an ADO2 for the anterior leak, and in the other cases, we use AVP3 for closure of the paravalvular leaks. This is the loop and curve technique in a patient with mechanical aortic prosthesis. As you see, we pass through the mechanical aortic valve very carefully, but we look at the blood pressure, always control the blood pressure, and then never use large delivery system. And then, but the blood pressure and hemodynamic was very good, and we closed the defect with 2 APP devices without using wire loop in this patient. Compared to the mitral paravalvular leaks, aortic paravalvular leak mechanism and localization are also different, and this is a very good surgical publication. Predisposing factors for development of aortic paravalvular leak is surgically induced anatomic change, aortic root anatomy and shape, LVOT shape, untrained and weak anatomic structures, prosthetic valve endocarditis, Marfan syndrome, bicuspid aorta, and severely calcific annulus. This is a classification of the surgical publication, but in the literature, this clog formation is completely different according to the different publications. So the mitral classification is okay, but there are, I think, this clockwise classification of aortic paravalvular leak must be revisited according to my opinion. But this is very important, right coronary sinus, non-coronary sinus, and left coronary sinus, and the relations between the sector of the periprosthetic leakage occurrence and the anatomy of the aortic annulus was investigated in this surgical series, and the most paravalvular leaks occur from the right to non-coronary cusp region. Because between 4 and 8 hour corresponds to the area above the membranous part of the interventricular septum and the right trigone of the cardiac skeleton, and basically includes the area of attachment of non-coronary cusp, and the embryologic origin of this leaflet and its portion of the annulus could be a reason for an intrinsic weakness. So this area is very important, right coronary to non-coronary cusp region, and this is the transthoracic and this is the transesophageal leaf. So we must be very careful to evaluate, although it's a simple mistake, where the transesophageal echocardiographic image and what is the transthoracic image. So the right coronary cusp is at superior on the transthoracic, but inferior on the transesophageal echocardiographic image. These publications are coming from the German group, and they identified the paravalvular aortic regurgitation on multiple views of transthoracic echocardiography and localization of the jets to a clockwise overlaid on the parasternal short axis view, and this new classification is much more adapted to the mitral paravalvular leak classification, and we usually follow up this clockwise method, and the determinants of leakage following TAVI also important, and bicuspid and aortic stenosis. It was really good, published by the Kerkhoff Clinic, and very good classification. So for the imaging, 3D is not good, 2D is okay, but aortography is for me very important during the procedure. So the aortography, if the, for example, leak is right to left or non-coronary cusp, we always use left anterior oblique angle, for example, LAAO 40 degree, cranial 20 degree, and make an aortography. If it is left to right or none, I made an aortography at right anterior oblique, and if it's lateral, none to left, I use also even lateral aortography. So what are the devices? Devices are AVP2, AVP3, but the most common devices we are using is the AVP3 and occlutech paravalvular leak devices. The occlutech is indicated in specific devices. There are rectangular W and square W device, 19 design and size options, square tip, rectangular, two shapes, and it gives much more opportunity to us and for its large sizes and to evaluate the paravalvular leak, and there was some problems, especially for the delivery systems of these devices, but now the new delivery system is performed, and it's this new ODS 3 is the reliable flex tier braiding technology, and it's very, very useful to cross even for from the retrograde approach and for the largest leaks. There are some side ports here and hemostatic valve and the minimizing blood loss and air entry, and three-wave stopcock flushing and aspirating before and during the implantation. Okay, so I want to present some interesting cases. 70 years old man, alcohol septal ablation was done in 2017, and bioprosthetic mitral valve replacement was done in 2021. And paravalvular leaks developed and referred to our Center for Paravalvular Leak Closure. Patient has severe heart failure, recurrent pleural effusion, class 4 symptoms, but no fever, CRP was normal, white blood cell was normal, and the blood culture was negative. We always evaluate this before the paravalvular leak closure, and also for the hemolysis marker, we evaluate haptoglobulin, hemoglobin, and peripheral blood analysis. These are very important tests before paravalvular leak closures. You can see here the severity of the paravalvular leaks. There is an anterior severe paravalvular leak at 10 o'clock position, and it was measured as 15 multiplied by 6 or 16, and the posterior severe paravalvular leak at 6 o'clock position here, 18. Medial paravalvular leaks grade 1 and 2, but anterior and posterior leaks are very severe and large leaks. Here you can see, but it is not a full dehiscence, but very large paravalvular leak, one here and one here. So we measured this distance because you know that the largest size of AVP3 is 14 millimeter, and the disc will be 18 millimeters. So we decided to use an rectangular W, the largest size of occlutech in this case. Here you can see the transeptal puncture. We always do the transeptal puncture without sheath, only the dilator, and put a spring coil guide wire in the left atrium, and then dilate the left atrium, like our in mitral balloon valvuloplasty procedures. And then after transeptal puncture, as you see that the bioprosthetic valve is not completely seen on the fluoroscopy, and we cross the anterior leak with mother and child technique and put a stiff guide wire. And then during this, after crossing the leak with the thermo guide wire, we always use a Navicross catheter because it usually allows to much good replacement of the an exchange for the stiff guide wire. And we select the 16 millimeter device of the rectangular W, open the distal disc of the rectangular W device, and close the leak. So you can see the appearance of the occlutech rectangular W device here. So then we cross the posterior leak and create an arteriovenous wire loop, because for the posterior leaks, it is very important to create an arteriovenous wire loop, because sometimes the angle is in this sample, angle cannot allow you to put your device properly. So if you have an arteriovenous wire loop, if you don't like the angle, you can come from the retrograde way. So arteriovenous wire loop is also very useful for the delivery system to cross the leaks. As you see, 18 millimeter device is not in a good position. So if there was a wire loop, for example, there was no need to recross the leak. So we changed the wire loop there, and we recross the posterior leak again with the modified pigtail approach. And then, sorry. Now, 18 millimeter device is very good position. So these are the largest paravalvular leak devices of the Occlutech rectangular W family. So think about the size of the leak. So this is the 3D appearance of after paravalvular leak closure. Both color 3D show that anterior and the posterior leaks completely close, and we don't want to spend any time much more for the patient to cross this medial leak, and we decided to follow up according to the hemolysis, and patient is very, very good clinical status now. This is another case, as you see, the septal region, the medial paravalvular leak. So we tried to cross the leak anteriorly, but we were not successful. Then we again crossed the paravalvular leak by retrograde approach and made the arteriovenous wire loop, which Onassis always called me the loop guy. So because of this wire loop, as you see, you can easily put your device, and if you don't like the position, it can you give an opportunity to you to change the device and your way. So it's very, very good approach nowadays. I always use the wire loops. And the second leak was recrossed by the thermoguide wire, and we used the long Occlutech delivery sheet. And this is a very interesting case also. You can see the large medial paravalvular leak. We crossed the leak again by retrograde approach and made our wire loop again. We tried to cross the leak by the classical delivery system of the Occlutech, but look at the, always the distal part is going to the upper part of the left atrium. So we decided to take the new ODS 3 system and come from retrograde approach and close the leak by the retrograde approach. As you see, there is no impingement of the leak. So there are some limitations, still limitations of current devices. The Ampitheatre family is not specifically designed for paravalvular leak closure. Off-label usage, morphology of defect represents great diversity, and atrial and ventricular orifices of these defects can be different. However, two discs, proximal and distal, are in same in Ampitheatre devices, and insufficient data still for the hemolysis. Delivery systems are not compatible with other closure delivery systems, but the long delivery system are limited only maximum to 7 French size. Thus, there is an important problem for retrograde closure of large defect with these delivery systems. But advantage of the Ampitheatre family is that you can use the largest size with 7 French delivery system, and you can also use, you know, Gregor's used the large sheet in the Oscar sheet in left atrium and multiplex approach. But Occlutech family devices are good and specifically made, designed for paravalvular leak closure, but all delivery systems were not good. You cannot use the largest devices with this old delivery system. New ODS 3 is solving a lot of problems, especially during retrograde closure of defects, designed mainly for transeptal and transapical approaches, and pushability and stability of the device in all delivery systems are re-examined, and I think and I hope new ODS 3 system will provide great benefits. Thank you very much for your attention.
Theo, thank you very much. Excellent presentation. You don't need to show the live case. You saw the cases, 3 cases. And can I ask you a question practically? You leave when you do the loop, which wire you leave? The Terumo wire? Because sometimes, you know, it distorts the position of the, which device, which wire do you use for the loop?
I always use Terumo guide.
So you leave the Terumo in and position.
Yes,
okay.
Yes.
So you have the access. That's very important, because if you lose the access, you have to start with again.
Sometimes if, for example, I never see, but some operators change the noodle guide wire sometimes, like in VST closure, but Terumo is always working.
Fine. Okay. So if, I don't know if you have any...
may I have a question on the topic when to close? Your decision to go with this operation depends on volumetric measures of the regurgitation or on clinical grounds and clinical signs? Anemia, shortness of breath?
This is a very good question. We especially look at first the clinical status and the clinical condition of the patient. Heart failure is really problematic for this patient, but when heart failure, for example, symptoms are prominent, when we look at the transthoracic image, paravalvular leaks we saw, but it's, for example, grade 1, 2. It is very important to do transesophageal echocardiography for these patients, because T shows the exact value of the paravalvular leak. Okay. And clinical hemolysis is very important and still is an unsolved issue. We are discussing a lot of these points. Why? Because of the inadequate endothelialization, residual leaks, relics after that I present the mechanism of the leak, the anterior leak and posterior contractions. So these are all unsolved problems for paravalvular leak closure. But the clinical data is much more important than the imaging severity of the paravalvular.
You would agree also, to finish, I don't know if because of time, that sometimes we close a patient who has cardiac failure, heart failure, and then if you leave a leak, you might develop an hemolysis. So sometimes, so it might change the indication. So that's the other thing that you have to consider.
Yes, but even with transesophageal, volumetric measurements are quite difficult and inaccurate. It is not so easy to be accurate in regards to volume, for example. That's why I'm talking about clinical signs.
We rely more on clinical, I think. That's what
yes,
you said.
Clinical. Vlasis is questions.
Okay, I think we're going to close the session.
Vlasis.
Vlasis? Yes, Vlasis.
If we have a minute, I mean.
Yes, go ahead.
One of the most difficult, congratulations, Theo. We've been in this together, and Professor Vavuranakis for some time now. One of the most difficult access points to close a mitral leak is the P2 area, 6 o'clock. And we've struggled sometimes transeptally. And we did the other day, we use your technique with the VA loop, and actually it works very well. It gives you tremendous support. I mean, Theo taught us how to do it, and we're grateful for that. It's one of the things that actually work a lot. Otherwise, it's very difficult.
Vlasi, to tell you, and I agree totally with you, sometimes, I manage to succeed just by putting the wire all the way down without actually looping it. So this can also help if you do not have the femoral access done, and patient is heparinized. And but you can always puncture with ultrasound, so you can get the loop actually.
But for the delivery system, large delivery system,
it's much better if you have
really, if you make arteriovenous wire loop, because before I was thinking opposite, that I publish without wire loop approach, but wire loop really helps you to cross the large delivery sheet inside the leak.
Yes, no doubt about that. You're right. So I think we're going to close now. We have a break.